It's time for the Kim Hammer Show, where you'll learn how your state government affects you, your family, and community. Here's Kim Hammer.
Good afternoon. Welcome to the Kim Hammer Show on another beautiful fall afternoon here in Arkansas. We know that bow season started up last week. I know many of you are out bow hunting and some of y'all getting ready for the game, so y'all just have a great afternoon. Want to start off by welcoming our sponsors to the show and appreciate them very much. That would be Everett Buick GMC down in Saline County there on Highway 5 at Alcoa. As I always tell you, great place to shop for a new GMC product, or whether you're looking to get a pre-certified used vehicle. They'll take care of you, make sure that they sell you a quality vehicle, whether it be new or used. And you can also get great quality service for all your car needs, automotive needs, whatever they may be, whether it's just an oil change. You can get in and out really quick, or other issues such as tires or whatever the case may be. They can take care of you all the way down there at Everett GMC Buick. Also want to thank Edwards Food Store. Was in the one in Bryant today. Super clean, well-stocked. They got a great sale going on, by the way. I've saved some money shopping there this morning. That'd be Edwards Food Store or Edwards Cash Saver, either one. They're both the same here in Central Arkansas. They've got stores all the way over Central Arkansas, even up Highway 67 all the way up to Beebe, and then over in East Arkansas between Marianna and up to Forest City and up to Harrisburg. So anywhere you're in Central Arkansas or there in East Arkansas, Edwards Food Store is a great place to shop. Get competitive prices, super clean stores, well-stocked shelves, everything you need in a shopping experience to make it pleasurable. You can even order online, have it ready for you. They'll be glad to deliver it to you at the curbside. And then also Baxley Phillips Mowdy Real Estate. They always take care of all your real estate needs here in Central Arkansas, whether you're buying or selling real estate or commercial, either one, residential or commercial, either one. They can take really good care of you. Also on the rental side, on the commercial or on the residential. In fact, I had somebody the other day tell me that they called them about some residential or commercial rental property, and they took care of them. So just goes to show that if you have real estate needs here in Central Arkansas, Phillips, Baxley Mowdy, or Baxley Phillips Mowdy is the place to go. You can look them up on the web, or they're in Saline County there at Highway 5 and Spring Hill Road. All right, today joining us, I believe, all the way from Indiana or parts outside Arkansas anyway. Our guest on the show today for the Kim Hammer Show is Laura Atkinson and Amanda Peterson. They are with a new company that was just recently authorized by the insurance commissioner here in the state of Arkansas to begin to offer product. And I actually went to the meeting where they were getting in front of the insurance commissioner's office in order to be able to do business here in the state. They are with a firm called Indy Health. In fact, if you were listening a few weeks ago, we did kind of a teaser, just a few minutes just to get things going, because they had not yet at that time been authorized to be in the state of Arkansas, but now they are. And so I want to welcome to the Kim Hammer Show Laura Atkinson, who is the chair of board of directors for Indy Health, and then Amanda Peterson, who is the CEO of Indy Health Insurance Company. And ladies, thank you for taking time out on this Saturday to be on the Kim Hammer Show.
Thank you. We appreciate the opportunity to discuss Indy Health.
So let's start off by just telling us what is or who is Indy Health, and how did you get started, and what was the conceptual idea behind how the company actually came to be?
Sure. This is Laura Atkinson. I'm one of the 9 co-founders who are independent pharmacy owners across the country who got together in 2016. We've all served in different capacities of leadership in the independent pharmacy arena with national associations and state associations, and have worked on both advocacy for legislative action and legal action. And having seen minimal results, we decided we would create a business solution to the current issues with regards to leveling a playing field for independent pharmacies in the industry. And so we began to create Indy Health with the intent on creating a transparent, innovative alternative to Medicare D plans in the market. And we've come a long way since the beginning days. As you mentioned, we not only have received authority to provide Medicare D products in Arkansas, but also in Georgia, Illinois, Pennsylvania, and West Virginia. And we are in the process now. October 1st, we went live to do marketing to consumers for our plans. In addition, we'll begin open enrollment on October 15th.
So as far as the concept for starting up, it was driven out of, I mean, I don't know how many companies there are. I think there could be 20 plus companies in the state of Arkansas that actually offer Medicare D plans. What was it that was occurring that you felt you were disadvantaged as a independent pharmacy that created the need for Indy Health?
Well, independent pharmacies, the plans and particularly the PBMs, they dictate the reimbursements to pharmacies, as well as who is in their network, who is preferred, who is non-preferred. So they basically dictate the terms of an independent pharmacy or pharmacies being part of their network. And there has been an ongoing issue with respect particularly to reimbursements and DIR fees. For those of you who are not familiar with DIR fees, they are a form of administrative fees that is assessed to pharmacies based on performance, and typically those are very egregious administrative fees, particularly for independent pharmacies who, of course, are at a disadvantage when they compete with the chains who are owned by the PBMs. And so we, as you're probably well aware, there in Arkansas, there's a Rutledge versus PCMA that is going to be held hearing on October 6th with the Supreme Court to address some of these issues with respect to the ability for states to regulate PBMs and unfair practices that occur in the industry. And so we created Indy Health. There's a practice now that a lot of the plans are opting to make independent pharmacies in a non-preferred status in a network, which that typically results in lower reimbursements as well as higher copays to consumers who utilize non-preferred pharmacies. So we've created Indy Health where independent pharmacies are preferred in our network, such that they have better copays for consumers who go to the independent pharmacies who are in our network, as well as better reimbursements than the non-preferred network, where we've kind of flipped it, where typically in the traditional model, you have the independents are typically non-preferred and chains are preferred. So we've kind of flipped it where the independent pharmacies are in the preferred network and the chains are non-preferred.
As far as that giving you, what does that do for the consumer at the end of the day? That is your business model unique to all the other companies that are offering, say, Medicare D plans or any other plans for that matter? Does your business model create a savings or benefit to the consumer at the end of the day, especially in the Medicare D? Because that's been a big part of the discussion in Arkansas this past week with the state retirees. Initially, we're going to be pushed off of the state-owned plan into the Medicare D world that decision got reversed, and it's back to where for another year, we're going to talk about that later in the show, but where they're back on the state plan. But with the business model that you have, does it create any savings, or what advantages does it create for the consumer?
Sure. So we have two different plans, and I'll give you a high-level overview and let Amanda speak more specifically to that. But so we have a Saver RX plan. This is a basic plan that individuals who require assistance from Medicare, who meet the low-income subsidy requirements, and those are plans where they receive assistance from the federal government. They can receive, depending upon where they are, meet in the tiers of the low-income criteria. They could qualify for zero premium and $0 copays. And then we have another plan called the Eliterx, which we call our chooser plan, which are those individuals who don't meet the criteria for low-income subsidy. And we're very competitive with most of the plans out there in the market, where we have a much richer formulary, meaning we cover a broader array of medications, which in turn results in lower out-of-pocket costs to consumers. And we also have very competitive copays. And I'm going to turn over the specifics to Amanda, because she's much more well-versed in this than I am.
Thanks, Laura. Senator, thanks for having us on today.
Thank you for coming
We're
on.
really excited about our products and being able to bring them to Arkansas and our other service areas. As Laura said, we really want to create a different business model. We are transparent to our pharmacies, transparent to our members, and there are savings that we're bringing to the Medicare beneficiaries that are out there. As Laura mentioned, we've got two plans. That Saver plan, although it's a Medicare standard defined benefit, so it's got the $445 deductible and no additional coverage through the gap, but it does allow those folks that have the extra help to be able to access the plan that will allow them to stay at their local independent pharmacy. In addition to that, there are several people that tend to enroll in those standard plans that don't have extra help. And for those members, we're offering $0 copays at their independent pharmacies. So, and that will really allow them to maintain that relationship with their pharmacist. Our Eliterx plan is designed such that we've got a $0 deductible plan, and our premiums are lower than the other competitors in the marketplace with a similar benefit design. When we were doing our market analysis, we were coming in 40 to 60% less expensive per month based on premium. And that's real savings to folks, because they're seeing that every month, instead of having to pay $70 to $90. Our premiums are right around $45 to $47, depending on which region you're in. So we're really excited about the opportunity that we have to bring savings to our community members. And again, they're able to access their local community pharmacy, which we think is important. Those local pharmacists, we know, have established and trusted relationships with their consumers. And they truly are out there looking out for their customers and their members. They also offer some additional benefits that you may not see in some of the larger chain pharmacies. We know that they do special things with packaging. They have special delivery options depending on the members' needs, and as well as other things that they do to take care of their members. So again, we're just very, very excited to be able to continue to promote and nurture that relationship between the consumer and their pharmacist that they've had established, and allow them to remain at those pharmacies and receive lesser copays than they would under a different plan.
It sounds like, in essence, you're taking the savings that would have otherwise been going to the PBMs or to, that otherwise would be going to corporate, and turning it back around into what would be savings to the consumer by changing the business model of how Medicare plans have been offered before. Is that a fair summary, or am I off target on using that comment?
No, that's absolutely correct.
So do me a favor, if you will, because when you get into, I've learned a lot in the last week dealing with all this as far as the state retirees. And by the way, if you want to call in, you got a comment, you can call into 501-823-0965, 501-823-0965. My pharmacist buddies are blowing up my phone listening to this. So if any of y'all want to call in on the second half of the show and chime in, you're more than welcome, 823-0965, or you've got a question that maybe you would like to have asked and answered, feel free to call into that number. So just back up for a second, because when it gets to the Medicare D and dealing with the federal government and what the plans look like, just kind of give me a Medicare D 101 for dummies explanation. I'm not 65 yet, but I see it looming on the horizon. Just kind of talk me through what the processes are, because I think it was October 1st. I could be wrong on that the feds released the new rates where you can go in and enter in your prescriptions and it'll tell you the best plan. Just kind of talk through the process for a minute and give me an education if I'm staring down that.
Sure. So there are 3 types of enrollment into a Medicare plan that a member can have access to. The first one is what they call their initial enrollment period. And so those are the folks that are getting ready to turn 65 or are becoming eligible for Medicare. So if your birthday it's a 7-month window. So it's the 3 months prior to the month of your birth, your birth month, and then the 3 months afterwards. And anytime within that 7-month window, you can enroll in a plan that will be effective your birth month, the first of the month for your birthday. After that, then every year in October, from October 15th to December 7th, there becomes Medicare's annual enrollment period. And that's what we are gearing up for right now. That will begin on 10/15. So on an annual basis, you can select a new plan based on, different parameters or things that might have changed in your life. So maybe your drugs coverage has shifted, you're on new drugs or not on the same drugs you were. You may need to make an adjustment or select a different plan if there's been a significant change in your premium. The pharmacy network may change depending on what plan you're with, or your copays or coinsurances could also change. So once you make that initial selection when you age into Medicare, if something happens where you need to reevaluate and find a different plan, you're able to do that on at least an annual basis. Then in addition to the initial enrollment period and the annual enrollment period, Medicare has what they call special enrollment periods. And special enrollment periods occur on a monthly basis. There are about 14 or 15 different types or reasons why you would be eligible for a special enrollment period. For example, let's say that you move from Oklahoma into Arkansas. And whatever plan you were on in Arkansas, they don't offer, whatever plan you were on in Oklahoma, they don't offer in Arkansas. So you're going to need a new plan, because to be eligible for Medicare Part D, you have to live in the state where you're a full-time resident. That's where you would apply for your coverage for. And then you have to be eligible per CMS's guidelines, and you have to be a citizen of the United States or lawfully present. And then you have to enroll during one of these types of enrollment periods. So if you move in or out of a region, that could trigger a special election period where you could change your enrollment. If you're someone who qualifies for extra help, and extra help is when the government will pay a portion a portion or up to all of, depending on your circumstances, your premium and your cost shares. So if you gain or lose that status or have a change in the level, because they have 4 levels of payment that you can apply for, that will trigger a special election period. The other one would be if you were incarcerated and just got released from prison, the month that you're released, you're then eligible for a special election period. Like I said, there's about 14 or 15 different reasons why you could have that special election period. So as long as you're in one of those 3 groups, so an agent, so in your example, you're getting ready to turn 65, that would be your initial period. And then after that, we are now going into our annual enrollment period where people can change plans for 1/1 of the upcoming year. So people that enroll between 10/15 and 12/7 of this year will have a new plan effective 1/1 of 21. And we're hoping that they check out Indy Health and we meet their needs.
So if I was to, are you up there with all the other companies as far as what's offered now? You know, part of what we were told is that you would go in and you could go up to the government website, you would key in all your different medicines that you're taking, and it would tell you the plan that best fits your need. Is that correct?
Yes. So on Medicare.gov, you're able to go in and do a plan compare across all the plans that service where you live. And Indy Health is on Medicare.gov. They call that the Plan Finder section. So you answer a couple questions particular to your individual circumstances. So where you live, if you have extra help or not. You go ahead and you put in what medications that you're currently on and how frequently you take them, and then and what pharmacies you utilize. And then Medicare.gov will come back and give you a list of plans that are in your area that best meet your criteria. And they will, I believe that they list them in order of lowest premium first.
So does that automatically put you all at the head of the pack then with your new model? Would that put you in the running?
So I've heard from folks that have been out there working on PlanFinder.gov that yes, a lot of their patients that they're checking their drugs, their pharmacy that's being used, and that we are coming up as number 1. Of course, every individual is going to be different, so I can't say that we'll come up number 1 for everyone. But the feedback that we've gotten so far from the folks that are out there checking benefits for various members have been very positive about our plan showing up as number 1.
I'm sure the big box stores don't like you, but anyway, this actually, and this whole concept is built around taking care of the independent pharmacists. Is that correct?
Well, it's really twofold. We wanted to.
I'm sorry. Go ahead, Amanda.
I was going to say, it's really twofold. We want to take care of our consumers, and at the same time, we also want to make sure that our independent pharmacists have an opportunity not to just barely survive, but turn it into an environment where they're able to thrive and keep that customer relationship.
Well, and in Arkansas, because we are such a rural state, that is one of the things I think that is critical to a lot of us is that when you take a look at where pharmacies are located, especially when you get into the rural areas, if it wasn't for the independent pharmacists, you'd have to drive 20, 25 miles. In fact, I had a story told to me of somebody down in southeast Arkansas that one of the pharmacists closed. It was an independent pharmacist, and it closed. And so somebody called them and said, "Hey, we know your pharmacy has closed. If you'd like to, you can drive to this," and it won't name the pharmacy, but it was a big box store. But the problem is it was 35 miles away. I guess as far as the, people trying to steer patients or steer individuals towards certain companies, what's going on out there in the pharmacy world where individuals are actually being recruited or directed to either the mail order or to away from the independent pharmacist, and how is that allowed to happen?
So if I could kind of speak to that in terms of how we've addressed that as part of our, when we are working with and we have to work with a PBM for the first 2 years as a requirement by CMS until you get 2 years of claims processing experience. So one of the things that we wanted to avoid, because many of the PBMs have their mail order mandate for their plans, and so we negotiated that we could carve out the mail order portion such that there's no PBM mandated mail order. And in addition, we negotiated 90-day retail terms for pharmacies, and also there's no restrictions with respect to our independent pharmacies and our network to mail to their customers. We saw that as a big barrier for access to patients, that they were mandating, mail order, and oftentimes there's issues, with mail order with duplicates and some prescriptions tend to, even though they're discontinued, pile up. So we addressed that early on in our negotiations to ensure that there was not going to be a mandated mail order, and such that the PBM that we're currently partnering with could not quote steer to our patients to their mail order. So we addressed that issue there. One of the things that we are very cognizant about as we have been doing trainings for our independent pharmacies is to avoid even the appearance of steerage, and ensuring that we're utilizing the tools like the Plan Finder and Medicare.gov to find the best plan for that patient, to ensure that they're looking at all aspects of the individual customer's needs, such as the premium, the copay, as well as the medication coverage, whether a pharmacies that they utilize as preferred or non-preferred. All of those things need to be taken into consideration.
Let me ask you, I know we slotted for 30 minutes. Could y'all give me 10 more minutes, or y'all have got a hard appointment to go to?
I'm good.
Okay.
I am too, Senator.
Okay. We're going to take a 2-minute break here on the Kim Hammer Show, and then we'll have Laura and Amanda with Indy Health come back on to answer a few more questions on the Medicare D side. And just want to thank our sponsors, which would be Everett Buick GMC down in Saline County. They'll take care of all your automotive needs, whether it's new or certified. Great place to go. Also to Baxley Phillips Mounty Real Estate in Central Arkansas. You can look them up on the web, or they're located there in between Bryant and Benton on Highway 5 and Spring Hill Road. Or also you can go over to Edwards Food Store, and a great place to shop. And we'll be back in just a minute. This is the Kim Hammer Show. Thanks for listening here on 101.1 FM, The Answer.
Hello, this is Jack Graham, voice of PowerPoint Radio, with a short word on the upcoming election. So much is at stake. Make your plans today and then vote.
A voice we need now more than ever. This is Charlie Kirk.
I was on the front lines of the greatest political upset in American history with Donald Trump Jr. We traveled the country. But what I am seeing right now makes 2016 look like a micron of that, just a fraction of it, a ripple in a pond. The intensity and the enthusiasm.
The Charlie Kirk Show, weeknights at 10 on 101.1 FM. The Answer. Take The Answer with you anywhere with our free mobile app, 1011fmtheanswer.com, your smart speakers, iHeart, or radio.com. Breaking news and stimulating talk. 101.1 FM, The Answer.
This is Dinesh D'Souza. My film Trump Card is the most important movie you will see before the election. It exposes the corruption and gangsterism that defines the modern Democratic Party and reveals what's unique about modern socialism, who's behind it, why it's evil, and how we can stop it. Order your video on demand and DVD now at watchtrumpcard.com. That's watchtrumpcard.com.
Starting Monday, the next big thing in conservative talk radio. Charlie Kirk speaks millennial to millennials. Weeknights at 10 p.m. Join Charlie Kirk for in-depth political and cultural analysis from the founder and president of Turning Point USA, a national student movement empowering young people to promote the principles of free markets and limited government. Tune in to the Charlie Kirk Show, starting Monday night at 10 p.m. on 101.1 FM. The Answer. Sean Hannity sees more cracks in Biden.
The amount of money going to nationals and, for example, from Hunter Biden back and forth, the wiring of funds, ending up in the hands and dealing with Russian oligarchs and Ukrainian oligarchs. It is breathtaking, an 87-page devastating beatdown and exposure in terms of how compromised Joe Biden can be.
The Sean Hannity Show. Afternoons at 2, right before Jay Sekulow at 5 on 101.1 FM. The Answer.
Hi, this is Robert Jeffress, pastor of First Baptist Church in Dallas and Bible teacher on Pathway to Victory. Let me encourage you to be in prayer about the upcoming election. Then make sure you prepare. Educate yourself on the agendas of the two parties and make sure you're registered. Finally, make your plan to vote, whether at the voting booth, by absentee, or vote by mail. Your voice is your vote. Your voice needs to be heard on November 3rd.
Be with us for the next journey into broadcast excellence.
Greetings to you, thrill seekers and conversationalist Rush Limbaugh, America's truth detector.
A broadcast like no other.
It combines two elements rarely found in the same presentation: the serious discussion of issues and an irreverent humor, both offering credibility.
He's America's most listened to talk radio host.
The doctor of democracy and the chief of the patriotism police.
And where do you find him? Right here.
Weekdays at 11 on 101.1 FM. The Answer.
Welcome back to the Kim Hammer Show. My guests today are Laura Atkinson, who is the chair of the board of directors for Indy Health, and also Amanda Peterson, CEO of Indy Health Insurance Company, a new company that's coming or being made available in Arkansas. They went through the processes, were approved by the insurance commissioner here in the state to be able to have their plans offered as part of the selection process. They are a company that is made up of independent pharmacists who have banded together to be able to offer another option in the Medicare D world. And recently, this past week, the EBD board, the Employee Benefit Division Board representing the retirees of the state of Arkansas that were state employees, reversed its decision and is going to allow for the over about 14,000 members to be able to pick over the next year whether they want to stay with the plan or whether they want to roll off and go to the Medicare D option. When it comes to individuals, like, say, for example, we were using me as an illustration, I'm not at 65, but I'm coming up on it. If that was me and I went up to the government website and I typed in all my medications and it produced for me what would be the best options, what goes into that? Because anytime you got the government determine what's best for you, that's not always a good thing. How do we know that the government is actually, through this program or through this website, once I enter my medications, doing what is best for me? And how would I look at that and determine for sure that that is really what's best for me?
So I think that the government website is really, they do a good job of presenting non-biased information. They are pulling information that the plan filed with CMS as part of the bid process as far as benefit design, copays, or coinsurance. And they are also pulling pricing information that comes from the PBMs into the Medicare.gov plan site. So I do believe that the planfinder.gov, it is a non-biased presentation of the plans that are out there. If you wanted to double check that information, you're able to go out to the individual plans websites, and each plan has a similar functionality where that you should be able to independently validate the results that you found on Medicare.gov if you just wanted to make sure that the Medicare.gov pricing display was accurate.
And so to what you just said, that is part of what puts you ahead of the game, is because you are dealing more, you, like all the other companies that want to participate in offering the Medicare D plan, y'all actually have to bid or submit to the government website what your proposed reimbursement cost would be, including any deductibles or anything else that goes into what that final price would be. For example, if I'm taking a blood pressure medicine and I type that into that website, are you actually competing against all those other companies to get that customer into your plan? And by submitting a lower price or less deductibles, that's what kind of moves you ahead of all the other ones. Is that the way it works?
That's correct. So every year in June, plans have to turn into CMS their bids. The bid process is where a plan defines to CMS what their benefit design is going to be, so copays, coinsurance, deductibles, as well as their premium amount. CMS then actually has an actuary that goes through and they review all the math that goes behind how that bid was calculated and formulated. And they confirm that the rules were done correctly and that it meets their standards, that they validate that the bids are accurate and appropriate. And then what will happen is that information that you submit into CMS, if they find something that, there's an error or something that they're questioning, if it's a question, they come back, you have a dialogue with the auditors. And so you either answer their question or you have to fix whatever they say is the issue. So there is an opportunity from June 1st until the end of August to where what you think your bid will be could change based on the results of those auditors, because they are double checking to make sure that you have accurately prepared your information based on the guidelines that CMS puts forth to participate in the program. Once those bids are finalized at the end of August, then CMS will release their contracts. And from that process, then they take that information, like you cannot change your benefit design. So for Indy Health on that Saver plan, we filed for plan year 2021 that we would have a $0 tier 1 generic copay at our preferred pharmacies under the Saver RX plan for plan year 2021. Halfway through the year, we can't change that and make that a $1 copay or $2 copay. Of course, that's after your deductible is met. So because that has a $445 deductible on the plan, if you don't receive extra help from the government, you will have to satisfy that $445 deductible to get the $0 copay. But again, once you those rates are locked in for the year, you can't change them. So from a competitive standpoint, then that's the information that they use to go on the Plan Finder display or the Medicare.gov platform to display the different plans.
If I may add something to the conversation here, one of the things that the Plan Finder does not do is it does not look at the individual pharmacies and their services. And so, that's one of the things that, needs to be taken into consideration. Many consumers utilize independent pharmacies for those services that the chains don't provide, such as, blister packaging, free delivery, that personalized service that a lot of the chains do not provide. And so Plan Finder does not evaluate that. So that's another key thing that consumers should take into consideration when they're looking at a plan is the pharmacy and the services that are provided, because some people need more help with their medications, with helping them be compliant and taking the medications properly, with the blister packaging, helping remind them when to take their medications and making sure they're not taking duplicates and there's no contraindications, and just having that personalized relationship with a pharmacist that they don't have with the chains.
That free delivery is a big thing in my area. All of our independent pharmacists, you see their vehicles running all over town doing that free delivery thing. Let me tell you, that's big. And especially, I think, in in a rural area, or if you've got people, that are housebound and maybe they don't have the family network to, make the deliveries. That's a big thing. One thing that's also interesting, I've got a couple guys in the church I pastor that deliver for some of the pharmacists. That alone provides a valuable service in that they are able to lay eyes on people. And there have been times where literally they had to call the police for a welfare check because somebody wouldn't come to the door, and they've had that relationship with them over a long period of time that they knew they should have been able to come to the door. And subsequently, they've actually had individuals that have fallen and, haven't been checked on for a couple of days. And if it wasn't for that, delivery guy delivering that message at that set time, that person might have laid there for who telling how long. So that is a service that is invaluable, in my opinion. That's just a editorial there on the side. You mentioned
You're absolutely correct.
You mentioned a while ago about did I understand you to say that you have to work with a PBM for the first 2 years?
Yes, that's correct. So it's kind of a hoop that startups have to work with CMS, is that there's a requirement that you have a minimum 2 years of claims processing experience in Medicare D. And so, as a startup, obviously, we wouldn't have that claims processing experience to process our own claims. So that necessitates that we, have to partner with a PBM for a minimum of 2 years.
And I guess that's probably a safety net for CDC. And for those that don't know, CDC is the federal, you've probably heard a lot about it, with all the, COVID virus. CDC is kind of like the government stamp of approval. You can do things. But go ahead.
I was going to say the big concern is that CMS has that they don't want beneficiaries to be impacted. It's so vital and critical that these patients be able to get their medications when they need them so that they can stay stable with their health. And if you don't have experience in the claims processing background and world, that can put the beneficiary at jeopardy. So that's the reason behind the ruling.
Right, which is a good thing for new starts. That way you don't have fly-by-night companies coming in and either taking people's money or getting people, moved away from other carriers. And, 3 or 4 months later, they go under, and then you've got a whole population that's, at risk. And I said CDC, but I meant CMS. Sorry about that a minute ago. Thanks for bringing that out. So once you get out from underneath the 2-year window and you have that, then you will be doing that yourself. And maybe you don't want to talk about that if that's proprietary information, but I would imagine that as time goes on, you become more proficient, and that savings can actually be passed along to the consumer. Your rates or your processes would become more competitive to where it'd make you more efficient at doing what you're doing. Is that a fair statement?
Yes, I believe that's a fair statement. Yes. So we will be looking at all possible solutions to reduce cost to the consumers, as well as be more efficient in our business practices.
Very good. All right. Well, I've kept you longer than when I originally had you scheduled on the show, but I appreciate it very much. We'll look forward to seeing how things develop as it goes along for Indy Health. And y'all have a website. I think you just got launched, didn't you?
Yes, we do. So if consumers want to learn more about our plans, they can go to indyhealthins.com.
All right. We've had on the show for the first 3 quarters of the show, Laura Atkinson, who is chair of the board of directors for Indy Health, and also Amanda Peterson, CEO for Indy Health Insurance Company. I think we'll be looking forward to talking to you more, and certainly appreciate y'all's creative ingenuity to get this going. It's going to be beneficial, I think, for the consumers and give folks a little bit better shot. Let me ask you one final question before I let you go, though. As far as people moving off like a private plan, onto a Medicare D plan, could it sometimes be beneficial for the participant to move off of a private plan to a Medicare D plan as far as what they might actually end up saving? And that's going to be a case-by-case situation. It's not a blanket statement. Is that a fair observation, or is that going in the wrong direction?
I think it really, you hit the nail right on the head. It really, really depends on each individual circumstances. If they have creditable coverage, which means that their coverage is at least as good as the Medicare benefit, those scenario or those folks, it may not make sense to move over to our plan. But if their benefit is not a creditable benefit, then yes, there's the potential for savings. But again, that's something that will have to be evaluated and reviewed for each individual person.
And I'm just thinking,
it really is dependent on what their current coverage requirements are.
Sure. And I'm just thinking about the situation here in Arkansas with 14,000 retired state employees, that some may evaluate that it's better to stay on the plan. Some may determine it's better to move over to the Medicare D. But in some ways, I think it would almost be beneficial if we could give them a case-by-case analysis if they need help in that guidance, just to make sure that they get the best, that we take care of them in the best manner possible, while yet at the same time trying to find savings. But it ends up being a case-by-case situation. So, all right, ladies, I thank you for taking time, and to your families, tell them thank you, because I know you've got a lot of things you could be doing on a Saturday, but I appreciate you being on the Kim Hammer Show. Look forward to more discussions in the future. That was Laura Atkinson and Amanda Peterson with Indy Health. You can go up to my website at thekimhammershow.com, and you can find that website that they mentioned, or send me a message, and I'll be glad to get that to you. All right, right now I have Blake Torres, who is with an independent pharmacy down in Benton at Westside Pharmacy, going to join me for a few minutes to finish up the show, because the ladies mentioned a while ago a phrase called the DIR, and which is basically an attempt to claw back from pharmacists some of those claims. So, Blake, I thank you for calling into the Kim Hammer Show today.
Yes, good afternoon, Senator Hammer. How are you?
I'm doing great. Great. Thanks for taking time to be on for a few minutes as we wrap up the Kim Hammer Show. Can you tell us, as an independent pharmacist, about DIR? They mentioned that a while ago, and just maybe give us some perspective from an independent pharmacist what DIR is and how it affects the independent pharmacist.
Yeah, sure. Real quick, and like you said, it's basically a clawback. It's a CMS Medicare initiative in Part D plans that originally started out as an incentive for pharmacies to take better care of their patients. However, with PBM's pressure in the market, it has turned into a profit-generating tool for PBMs and insurance carriers, where basically what happens, Senator Hammer, is we receive a payment from the PBM at the time of sale. So say we give a patient metformin. They pay us $10 at the time of sale, and then 3 months to 6 months later, they come back and take $3 to $4 out of that $10 payment. And the even greater issue is we have no idea exactly how much money they're going to take back from those individual Part D claims.
So give me a lesson in 101 dummy explanation on this, because when, the ladies were just talking about that when they submit their plan, that they actually have to bid on it and that they have to hold that price for that entire year, if I understood what they were saying right. So as far as the clawback, is the clawback occurring on the part of CMS, or is the clawback coming from the PBM?
The clawback comes directly from the PBM. And then the copay amount, the Tier 1, Tier 2, Tier 3, that will stay the same for the patient. So the patient's copay, in theory, can remain the same, but the amount of money that the pharmacy receives is the clawback portion. So we can go from making $5 to be able to keep our doors open, to be able to continue to offer free delivery on a prescription, to when that clawback occurs, that we lose $5.
And the biggest thing is you don't know when that comes. I guess what gives them the authority to be able to claw back like that? Are they saying that CMS is changing the rules on them, or is that just an arbitrary decision on their part that they're able to claw that back from you?
So that's a manipulation based on CMS guidelines that were established early on that said they can design plan benefits to incentivize what they call quality measures. Things like making sure a patient picks up their medication, making sure diabetic patients are on a cholesterol medicine. But instead of using it as an incentive and saying, if you do this, we'll reward you, they basically say, the goalpost is here and you can't obtain it, no matter how quality of care you provide. And thus, we're automatically going to take $3 back, and really, Senator Hammer, it's a percentage, and it's a minimum percentage. So no matter what, they're going to take money back, no matter how good a care we provide.
So as far as your options of PBMs that you do business with, are there other? Do you have a choice of PBMs that you as an independent pharmacist can use, or why is it that you would stay with a PBM that would be doing that to you?
So, we stay with them because we care for patients. Westside Pharmacy has been around since the 50s, Smith Caldwell, so on and so forth. We care about our patients. Unfortunately now, 3 PBMs own over 80% of the market, and they have basically built a monopoly or an oligarchy, so to speak. And not only are they processing prescription claims, they might also started buying insurance companies such as Aetna, United Healthcare, et cetera.
And if I remember right, the PBM's got some strength and you correct me if I'm wrong on this, but it seems like I remember this from a previous conversation as far as when Obamacare went in, did that give the PBMs, did it strengthen them any as far as doing what they're doing?
Yes. So it opened up an additional patient population as well as allowed for managed care Medicaid. So took off some shackles and allowed them to play in a different arena with different rules. Yes, sir.
All right. Well, I've only got about 2, maybe 3 minutes left. So let me ask you this. On the PBMs and the fact that they were able to get 80% of the market, is there a way around the PBM, or why is it that you are locked into having to do business with the PBM? Why can't you just go out and buy the drugs and do an end around of the PBMs?
So the only way we can do that would be direct contracting with employers. But that doesn't exist in the Medicare Part D market because CMS dictates to the insurance companies, like Amanda was saying with Indy Health, that they have a PBM processor. And so right now, the 80% of the market is controlled by those 3. So we can do the go around, just not in the Part D market.
Okay. All right. Well, you've been listening to the Kim Hammer Show. I thank Blake Torres for calling in. He is with Westside Pharmacy, and I've got a lot of friends that are independent pharmacies, but he called in, and so I just appreciate the insight that you're giving today. And one thing that's going to be important for you to watch is this Tuesday, as the ladies mentioned earlier, the Supreme Court is actually taking up a case that our Attorney General Leslie Rutledge filed on behalf of some legislation that was run back in 2015 and subsequent legislation as well. But that's the primary one, and it could have a direct impact on how things are done in the pharmaceutical world. So pay attention to that. Hopefully it'll weigh out on our side. Everything would indicate that it is, and hopefully that's going to provide delivery of pharmaceutical needs at the local level. This is Kim Hammer. You've been listening to the Kim Hammer Show. I want to thank my sponsors, which would be Everett Buick GMC down in Saline County, Baxley Phillips Mouty Real Estate, also in Central Arkansas, and then also Edward Food Stores here in Central Arkansas and over in East Arkansas. Just want to remind you, if you would, regardless of however you feel about him, everybody deserves a prayer. So just remember our President and First Lady, as they also have been diagnosed with COVID-19, but things are looking good, and so we're glad for that. But remember them in your prayers because we just want to do it. It's the right thing to do. Hope you have a great Saturday. And again, thank you for listening to the Kim Hammer Show. You can catch the video on YouTube or up on my website, www.thekimhammershow.com.
101.1 FM, The Answer. KDXE FM, Kamak Village, Little Rock. A Salem Media Group station. 101.1 FM, The Answer.